So welcome everyone to our webinar hosted by Intensive Care Nutrition Fellowship at the World Intensive Care and Emergency Medicine Institute. Today we will explore key advancement in nutrition care for critically ill oncology patients. This is a challenging topic, really very challenging topic with many important questions to be answered. One central question we aim to address is whether cancer is primarily a metabolic disease that can be improved through nutritional interventions to improve mitochondrial biogenesis, for example, mitochondrial functionality, such as starving cancer cells with ketogenic diet, or it is a genetic disease requiring personalized medicine to target gene mutation, or a kind of dysbiosis issue with alteration in microbiome. Today we will actually identify, is it a fact or fiction, what we are listening in the media, and we will listen to the expert from Hamda, Nicole, and Alessandro. It's my pleasure to introduce speakers at the session. We have Hamda Al-Zuhair. She's the Director of Clinical Nutrition at Al-Musa Hospital. We have Alessandro Laviano. He's Associate Professor at Sapienza University of Rome and Chief of Clinical Nutrition at Sant'Andrea University Hospital. Professor Alessandro is recognized among the top 2% of world scientists. Nicole Andrews, she's an expert dietitian in oncology nutrition from US. I hope the webinar will be of great value for all of you. Initially, I would like really to share with you the short video about our fellowship.
Cover the next level of critical care expertise with the Intensive Care Nutrition Fellowship, a phenomenal program for aspiring professionals in the field. With the increasing importance of nutrition in critical care, this fellowship fills a crucial void in training. It's not just a program, it's a deep dive into advanced clinical nutrition. About various critically ill patients across different specialties. This includes medical, surgical, cardiovascular, renal, hepatic, oncological, transplant patients, and more, encompassing both enteral and parenteral nutrition. Upon finishing, attendees will be capable of confidently and securely formulating nutrition plans and managing any related complications. Join the fellowship to reshape healthcare and transform your dedication to patient care into a leadership role in critical care nutrition. Whether you're a beginner or a seasoned professional, this program offers the perfect platform for growth. Your path to becoming a healthcare innovator is just a step away. Don't let this chance slip away. Embrace your future in critical care nutrition with the Intensive Care Nutrition Fellowship. Your journey to becoming a healthcare hero starts here.
Okay, so we will start our webinar.
Yes, I'm here.
Hi there, how are you?
Hi, very well, thank you.
Yeah, are you ready to share your screen?
Oh,
because
sure.
Difficulty. Yeah.
Absolutely, yes. I hope you can. I hope you can see my screen.
Yeah, we can see your screen well.
Okay, good. So I can start.
Yes, so welcome Alessandro. Alessandro, Professor of Internal Medicine at Sapienza University of Rome. And he is the director of the ESPIN Life Long Life Courses program. Alessandro is very well known in the field of the cancer nutrition. And I hope the lecture will be of value for all of you. Floor is yours, my dear.
Okay, let's keep our fingers crossed. First of all, I would like to thank you for inviting me to give this very hot topic, but not easy one. Of course, before starting, it's important for me to share my potential conflicts of interest, which I summarize in this slide. I believe that to address the issue of what is really new in the care of cancer patients in ICU, we have to answer the questions. So are critical ill cancer patients metabolically different from critically ill non-cancer patients? Okay, if you look at the literature, you would say no. The main difference between cancer patients and non-cancer patients is really minimal. So basically, we can apply the same guidelines which have been published. For example, these are the ESPEN guidelines, which everyone knows very well that we have to screen the patients, we have to prefer enteral nutrition, we have to provide a certain number of calories, a certain number of proteins, and you know very well that these guidelines have been implemented all over the world. We know very well that sometimes it's quite complicated to reach the targets of the guidelines, and that's why, for example, sometimes it's necessary to complement enteral nutrition and parenteral nutrition. This is just one case showing that in some days of the stay of these patients with cancer in the ICU, some of these days are completely reaching the targets by enteral nutrition alone, but other times you need to add some kind of supplemental parenteral nutrition. The same applies with the protein. Now, the good point is that if you really provide the exact amount of proteins, or approximately the same amount, then of course you may have a positive nitrogen balance, meaning that you can in some way mitigate the muscle loss which is associated with the ICU stay. Now, we know very well that everyone on this planet knows that we have to start our treatment as soon as possible. But again, you see that in this nice study coming from the UK, approximately only 1/3 of the patients receive an early enteral nutrition. About 31% of the cancer patients being critically ill receive early parenteral nutrition, but until discharge from ICU, and basically another 17% receive early parenteral nutrition and food. Now, we also know that if you ask for the reasons for delayed or omitted enteral nutrition, 2/3 of the case are actually asked per surgical medical team decision, meaning that sometimes it's the doctor who says we don't want to start early enteral nutrition. Now, can we do better than that? And now we start really what is really new in these patients. For example, we know, everyone knows that sarcopenia, meaning the loss of muscle mass and muscle function in patients with cancer, is one of the main characteristics of this kind of patients. So the case is, can we do something maybe to improve sarcopenia in these patients, particularly in patients with cancer? Now, first of all, we have to say that there is a high prevalence of pre-existing sarcopenia in patients with cancer and admitted to the ICU. These are data coming from France in Europe, and they're actually looking at patients with hematologic malignancies who are admitted to intensive care for sepsis or septic shock. Now, you see nicely here that during the ICU stay, it seems that particularly for male, there is a reduction in the quantity of muscle mass, while it appears that particularly for the ladies, the red boxes, it appears to be more stable. Well, this is much better shown in these in the other slide, showing that again, patient with hematologic malignancy admitted to the intensive care they have at baseline approximately 65% of them, they have already sarcopenia if you measure at L3, but if you measure at actually T12, it's approximately 83%. Interestingly, the male increases, but not so much the ladies, which means that maybe women are more protected by the development or maybe by the progression of sarcopenia. What is important also to note is that patients with pre-existing sarcopenia appears to have a potentially worse outcomes. You see that the statistical significance is not reached, particularly when you measure sarcopenia at the level of T12, though this difference appears quite important, and the significance levels is on 0.062. Now the question is, but can we protect it? Can we protect the muscles in patients with cancer and undergoing an ICU stay? There are different strategies in which we can do that. For example, the moderator has already introduced the issue of pharmacological protection, particularly of the mitochondria. This is a nice basic study. In this study, we're using a specific pharmacological drugs. And you see nicely here that if you use this drug, you can have a significant improvement in the peak torque of the muscle of these animals, showing that if you, of course, you have to provide the exact amount of calories, of proteins, of micronutrients, but if you in some way you use a pharmacological strategy to protect the mitochondria of the muscles, then you can maximize the anabolic effects of the nutritional support, the standard nutritional support, and therefore you can maybe prevent the so-called post-ICU acquired weakness. Now, another important aspect, and this is a study which has been published today, really today, it came out today. Can we only do something on the pharmacological point of view, or we can do something else? I was interested this morning when I read this paper because suggests that if we can in some way modulate the epigenetic milieu of the muscle mass, you can improve the metabolic flexibility in obesity. Now, the study is quite complex because it was basically mentioning that by blocking a specific enzyme, which is associated with the increase of the reduction of the telomere length, actually you can improve the metabolic flexibility. So the muscles are more prone to improve the mitochondrial biogenesis, increase oxidative phosphorylation, and you can improve the endurance capacity, but also, as you can see here nicely, you also can improve the metabolic health of the muscles. So please keep in mind this possibility. So working on the, I would say, the methylation of the DNA, you can in some way improve the metabolic flexibility of muscles and therefore protecting them from, I would say, from the stress. There is another important aspect, particularly in patients with cancer undergoing a stay in the ICU, which is inflammation. Well, we know very well that inflammation is really a situation, a clinical situation, which is found in all patients, independently from the presence or not of the presence of the tumor. But we know, and this is important, that particularly in patients with cancer, high inflammation is associated not only with a poor outcome during critical situation, but also with a more aggressive tumor phenotype. So the idea is, can we modulate the inflammation? And by doing that, can we also help the patients to have a better recovery, but also a better efficacy of anti-cancer treatment? I don't have to remember what is already very well known, that basically there are many studies with eicosapentaenoic acid and docosahexaenoic acid as a modulator of the inflammatory response by reducing the production of pro-inflammatory mediators and I would say increasing the production of less pro-inflammatory mediators like the prostaglandins E3, thromboxane A3, and leukotriene B6. And not to forget that also using docosahexaenoic acid, you can have the production of resolvins and protectins. Now, I told you before that so far we are using, I would say, modulation of inflammation in critical care patients by omega-3 fatty acids because we want to prevent chronic inflammation, but we don't want to completely suppress the inflammatory response. So we just want to modulate the inflammatory response to avoid chronic inflammation and, I would say, improve the resolution of inflammation. However, please remember that particularly in patients with cancer, the use of omega-3 fatty acids is associated with some metabolic effects which are positive for the long-term outcome of these patients. For example, they block migration and invasion. They are able to activate apoptosis of cancer cells. They are able to increase autophagy of cancer cells. So there are some effects that can extend the normal positive effects on the outcome, on the clinical outcome of patients in the critical ill. But how can we do that? Well, I think that this nice paper published by Christian Stoppe and co-workers a few months ago can provide us some ideas. For example, should we always use the same amount of, for example, omega-3 fatty acids? Maybe not, but then we have to move towards the so-called precision nutrition, particularly in critical care. But this means that we have to modulate and more importantly, to monitor the metabolic status of the patients. And for example, increase the amount of omega-3 fatty acid when we have an increase in the magnitude of inflammation, and maybe reduce it when the inflammation is going down. Now, how to do that? Well, this is very nice to be discussed, but it may not be so easy to be done in the real world. You know that there are a number of potential biomarkers which may guide nutrition support in critical ill patients, and particularly in patients with cancer. Of course, we are using a lot C-reactive protein, of course, nitrogen loss, blood urea, but at the end of this talk, I will discuss with you some potential new strategies to see and to assess the stress, the metabolic stress of our patients. Now, I would like to introduce the really new concept in the modulation of the metabolic status of patients with chronic disease, but also with acute disease. And to do that, we have to distinguish two major issues: age versus aging. Now, if you look at the prognostic determinants of outcome for example, patients with cancer undergoing emergency surgery, you will see that there are a number of different effects, like, for example, age, or maybe these, I would say, functional status, the so-called American Society of Anesthesiologists Physical Status Classification, the lymph node ratio, adjuvant chemotherapy, and sometimes you see nicely here the difference it makes on the outcome of these patients. Now, the question I always had is, but how is it possible that if a patient receive adjuvant chemotherapy, this is actually a good or a bad prognostic factor. I will come to that in a few moments. And also we know that age is important in predicting cancer recurrence. But again, adjuvant chemotherapy, or maybe the lymph nodes retrieves, the gender, and so on. Now, of course, malnutrition is important. This is a nice and recent study. I would say the prognostic factors with the 90-day return home, and of course, malnutrition is there, which means that we have to fight malnutrition, which means that we have to implement the ESPEN guidelines or the ASPEN guidelines in terms of providing the exact amount of calories, the exact amount of proteins, not too much calories, not too much proteins, not too low calories and proteins. But how can we actually understand what is really specific to the patients? And this is the new concept coming on. Now, you know very well that every cell of our body undergoes replication. And when the replication ends, maybe after 1 day or maybe after 10 years, the cell goes into apoptosis and disappear. Unfortunately, some cells, which are called senescent cells, do not go into apoptosis, but they remain in this quiescent state and do produce substances which heavily influences the outcome of the patients. And these senescent cells are increased not only by the age, so the older the patient is, the higher the number of senescent cells in the lung, in the heart, in the muscle, in the brain, whatever. But also, for example, the chemotherapy or renal failure or inflammation, they increase the number of senescent cells. Now, this is why, for example, quite recently, a number of the nomogram have been developed to predict the outcome of patients. And you see nicely here that basically no nutrition factor is included. Of course, you would say, oh, but there is albumin here. Yeah, but you know better than me that albumin, particularly in critically ill patients, cannot be considered as a nutritional marker. And we know that indeed these prognostic score really identify the survival of patients with cancer. So the concept here is that we have to distinguish chronological age versus biological age. Let me try to explain this new concept, this new idea. So chronological age is very simple. I mean, there is absolutely no difference between being 25 and 35 or being between 85 and 95. The change is not occurring, never. This is different from biological age. Biological age is, I would say, a marker on how rapidly our organs age. So maybe you may have a period in our life in which our biological age is increased when compared to chronological age, but also there are moments of our life in which our biological age is lower than the chronological age. Then you will say, okay, but who cares? Who cares about that? No, this is important. Let's make an example. Let's say that at some time in the life of this guy, this patient, a catabolic stress occurs. Could be a surgical operation for cancer, or being admitted to an ICU in a patient with cancer. Now, if we look only at the chronological age, you see, that is his age. He's 75, he's 65, 56. But maybe at that time, the biological age is quite different. And this difference is called age acceleration. And age acceleration is the new concept which may help us in more precisely characterize our patients. Why I'm saying that? A couple of years ago, this paper came out. This is a paper coming from, I think, from Europe, showing that if you do not measure chronological age, but actually biological age of your patients in the ICU, this will be a better marker to predict the hospital mortality. So if you really want to characterize your patients, particularly the patient with cancer, it's better to actually look at the biological age rather than the chronological age. And of course, maybe you can think, well, but I know that to measure biological age, I have to measure the telomere length, the methylation status of the DNA, so it's very complicated. It takes ages before getting the results. Now it is much easier. There are a few the biological clocks which helps you in less than 3 minutes to estimate reliably the biological age of the patients, and therefore you can immediately check which is the real age of your patient. And so this may also explain how this could help when protecting the muscle mass, the mitochondria, how to assess whether our intervention is effective. Remember what we already discussed about the methylation of the pharmacological protection of the muscle mass. Another very important aspect is that the biological age really is associated with the stress. And more importantly, it responds quickly to changes in the stress levels. So you have an increase in biological age during stress, and you have a reduction of biological age during recovery. Now, just to give you some example, this is a very nice and recent study showing that patients undergoing, for example, surgery, they have an acceleration of their biological age during surgery, and then after surgery, there is a reduction in this acceleration. Again, this is for the use, for example, of a drug which is used, of course, with cancer. And again, you can see nicely here that there is a reduction in the pheno age in the patients which are, I would say, in the patient who are responding to the immune checkpoint inhibitors. Not only that, there are now a number of studies, animal studies, of course, still animal studies, showing that using specific drugs which are not working on the proteins, on the calories, but just blocking these this accelerated aging, you can have an improvement, for example, of the chemotherapy-induced cachexia. Now, so the idea is, okay, then we can in some way consider muscle mass as a biomarker of acceleration of biological age. And indeed, this recent study you see was published in January 2025 shows that inflammation mediates for at least 35% the acceleration of the biological age. Now, how can we do this? How can we use this information for our patients who will be taken care by us tomorrow or next week? Now, one important aspect has been discussed last year by Ken Justen at the Arvid Bretlind presentation during ESPEN 2024 in Milan. And he was saying, be careful. Do not feed too much the patients. Really try to stay within the safe range of the calories, particularly during the first days of the admission to the intensive care. Of course, he was actually discussing what happens in critically ill children, but possibly we can, I would say, extrapolate these information also to adults. And interestingly, he was saying, as I told you before, that these kind of cautious intervention during the stay in the ICU is associated not only to an improvement in the discharge from the pediatric intensive care unit, but after years, these patients have a better visual motor integration, improved executive functions and behavior. So again, as I said at the beginning of my talk, it's very much interesting to see that probably even a short stay in the ICU for a patient with cancer, if properly taken care from the nutritional point of view and the metabolic point of view, may have significant effects not only during his stay in the hospital, but possibly even years later. So in conclusions, I think that we have to consider that the currently available guidelines on nutrition ICU patients probably fit the needs of critically ill patients with cancer. However, there are a number of areas of improvement, and maybe this suggests that ICU stay may represent a window of opportunity for patients with cancer. Rehabilitation of patients with cancer or the intervention to protect muscle mass may favor positive outcomes. Modulation of inflammation may serve, of course, to expedite recovery of the patients, but also to mitigate cancer aggressiveness. And finally, the modulation of biological age may further restore patient resilience. And again, I would like to thank everyone for inviting me. And of course, in the Q&A session, I will be more than happy to discuss every doubt you may have. Thank you again.
Thank you very much. Thanks, Alessandro, for a very nice presentation. I think you tackled the cancer from main aspects of metabolic disease, and you agree about the mitochondrial functionality will be really an issue with cancer patient. Now we're going to listen to Nicole Andrew. And Nicole Andrew, she is an oncology dietitian, considered one of the most influential cancer dietitian specialists internationally. She's practicing cancer dietitian and nutritionist for almost 15 years. She is dealing with adult and pediatric cancer survivors, and she owns an international center. She's coaching for that. It's called LLC. We will hear about different aspects. Is really a dysbiosis issue related to cancer, and can we modulate really cancer outcome with the alteration of microbiome? Thanks, Nicole, and the floor is yours.
Thank you so much for having me. I appreciate you having me here. Let me pull up my slides. Hopefully this will go smooth. Just wait for me just a couple seconds here. I'm really excited to talk about this. Try one more time. There we go. Perfect.
Yes, great.
Wonderful. I don't know why. I share it and then it disappears. All right. Hi, everyone. My name is Nicole Andrews. I'm a registered dietitian here in the USA of over 15 years. Today, I'm going to be talking about the gut microbiome and oncology ICU patients, the new nutrition insights and the clinical strategies that we can use to really take care of our patients, which is so exciting. So first off, let's just talk about why does the microbiome even matter? Why does it matter for our critical care oncology patients? Well, it's going to help to regulate some pretty important things that are going to improve their outcomes and their healing and just how they're doing overall. Their immunity, their inflammation, and also their metabolism. Obviously, these are key, very key for our ICU patients. unfortunately, cancer patients, they are more of a high risk for gut dysbiosis due to their treatments. So that's going to be chemotherapy and immunotherapy, but also if they're needing and using, or prescribed antibiotics. Dysbiosis is also associated with worse outcomes. With worse outcomes, there are more infections and longer ICU stays, of course, what we're trying to really avoid. So looking at and supporting gut health in our patients is going to help them. So key question, can we target the microbiome to improve outcomes in our critically ill oncology patients? The answer is yes, and we're going to talk all about that more. So I just want to really clear up and just gut dysbiosis, what actually is that? It's really when it occurs when there's a microbiome imbalance. So that balance of that good and bad bacteria in the gut, it's disrupted. So no longer we got the healthy gut bacteria and then the bacteria, the live bacteria and then what's feeding it, it's all disrupted. Unfortunately, this can come about for several different reasons of our cancer patients. So just, knowing that when they're going through chemo and immunotherapy, when they have infections or on antibiotics, when, there's certain nutritional support mechanisms. So, parental nutrition, for example, there may be a lack of fiber and prebiotics. So it's just going to be harder on their gut. One of the consequences of gut dysbiosis is poor recovery. So we want our patients to recover quicker. We want them to feel better. Sometimes what will end up happening is we're overlooking the gut. We're overlooking how is this even tied to them recovering quicker? So being able to support them with the right strategies is actually going to help them recover quicker. Our goal as clinicians is to restore the microbiome balance to improve those outcomes for our patients. All right, so first I'm going to go through probiotics and symbiotic strategies. Symbiotic strategies are probiotics with prebiotics. Probiotics are just the live bacteria on their own. So one of the challenges of supporting our patients with the right gut strategies is that some of these probiotics can pose risks on our immunocompromised patients, which is a big thing for our, specifically for the oncology group. Our goal is to definitely support their gut health, but we need to be mindful of who's immunocompromised. So the first strategy would be to offer probiotics, the live bacteria, to our patients. How this would help? So a few different studies found 3 different outcomes based on these specific live bacteria here that I shared. It would reduce the antibiotic-related diarrhea and infections. Certain bacteria can actually help maintain the gut integrity even during treatment. So being able to offer gut support, maybe not waiting until it's really bad or down the road, but actually early intervention. If someone's on chemotherapy, it may be a really good idea to get them on those probiotics, those live bacteria. Also, the antibiotic-associated diarrhea is an issue a lot of times for our ICU oncology patients, is wiping out their gut, all that good bacteria, all the food, the pro and prebiotics that feed that good bacteria. So just trying to not only provide them with probiotics, but early on, one study had even shown there's 26% fewer infections for those ICU patients that were given probiotics. What is more recommended than just probiotics is symbiotics, where this is a combination, which makes sense because probiotics is your live bacteria within your gut, and then prebiotics is going to be that food for the good bacteria. A lot of people will throw around pro and prebiotics, but people don't realize that one is the live bacteria and one is feeding it, okay? So you want to really try as much as you can to be giving your patients symbiotics. It does offer more gut protection. So because ICU patients have weaker gut barriers, it's going to let that harmful bacteria into the bloodstream. Symbiotics, which is a combination of pro and prebiotics, do help to strengthen that gut lining better than probiotics alone. Okay, when that happens, it's going to reduce that infection risk. Specifically, one study had found that using symbiotics actually had reduced ventilator-associated pneumonia in ICU patients. So that's also something to consider. Supporting the gut health with not just probiotics, but also prebiotics can actually help to reduce complications. All right, so how are these pro and prebiotics going to be delivered in the ICU? So we always want to, of course, as clinicians, ensure safe and effective support for our patients. There's a couple different ways because sometimes our clients, or excuse me, our patients will have swallowing difficulties or gut dysfunction or be immunosuppressed. These are, these are challenges that are going to come up that maybe you won't be able to support them, or we have to just look at different ways. So here's a few suggestions. You have your enteral tube feeding, which is always your preferred route. We want to stimulate that gut when we can. We want to keep it moving and working. You could do certain probiotic powders or capsules, NG, OG, PEG tubes, those can just be mixed in with the enteral nutrition, pretty easily. And then sometimes there'll be even symbiotic enriched enteral formulas. So they would already contain those pro and prebiotics, which is pretty cool. It's already ready to go for you. If the patient is allowed to swallow, you can, just do your capsules or your tablets. Of course, obviously, these patients need to be stable, non-intubated. And then even for patients who are even more stable, you could do certain yogurts. The timing and dosage. So within the first 2 days of being admitted, as long as it's safe for your patient and you have things set up, the right enteral nutrition, or they're able to, eat food by mouth, you can go ahead and do that within the first, 48 hours. And then neutropenic patients, they have more of a risk of bacteremia. So we may want to be more mindful when offering them the support for their gut. Always work with the dietitians. It's a group effort. Always, of course, collaboration is going to help really make sure that the whole team is watching the patient and we're able to look at everything, including that gut. Your dietitian is going to be your bestie coming in there, really advocating for their gut health. So making sure it's a collaborative effort. Antibiotic stewardship strategies. Basically, there is going to be times where patients need antibiotics. What I want to point out, what studies had found, is just really, when we can get them off of antibiotics, when they need antibiotics, because that will really significantly impact their gut health. And of course, what we already talked about is when their gut, is really impacted, those good and bad bacteria are wiped out. They just don't have as good as outcomes. So a couple things. One of the challenges I do want to point out, that broad spectrum antibiotics can really disrupt gut bacteria in our ICU patients. It can really worsen outcomes. I know we're all working so hard to have the best outcomes for our patients. A couple different strategies that have been shown through studies. You could do FMT for recurrent C. diff. Of course, de-escalating those antibiotics once that infection is completely ruled out, and then using narrow spectrum antibiotics when it is possible. FMT was successfully restored gut bacteria, or excuse me, gut balance in ICU patients. One study had shown that. Certain antibiotics can be considered high risk for gut health and antibiotic resistance. These ones specifically here had been shown through certain studies to have higher risk of gut dysbiosis or killing off gut bacteria. You may already be really well aware of that, but just trying our best to be super mindful of supporting the gut health around the antibiotics that our patients are on. Let's now transition to talking more about dietary strategies to support the gut microbiome. So just kind of like a whole general thing to consider when we want to support our gut health for our patients at any stage, and I understand, these are our critically ill patients, is you really want to think about three main things always, whether they're critically ill or they're not, is fiber, pro, and prebiotics. Okay, those are the three amazing things to help support and stimulate the gut. Okay, and to support that really healthy microbiome. And so today we're really talking about kind of the nitty-gritty ways to support our critically ill patients. But as a clinician, those are the three things you just kind of want to have on your radar at all times to support gut health. So right here, I'm talking about because a lot of our ICU patients do depend on enteral nutrition, parenteral nutrition. There's maybe some challenges to administer the right support, the right pro and prebiotics. But here are some ways that you can actually help to support your patients and how you can administer. So first of all, there are high fiber enteral formulas. With those, and you may have experienced, they can have some side effects with higher fiber. So it's not good to just give your patients a high fiber formula. A dietitian should be on your team and helping you, but making sure they're really well hydrated. So with a lot of fiber, it needs to become, the right amount of water with that enteral nutrition. It did actually improve response to immunotherapy in critically ill oncology patients. Omega-3 enriched formulas, I'm going to break this down a little bit more for you. Omega-3s are anti-inflammatory. They're going to reduce inflammation, which is always really important for our patients. And then even omega-3s, those anti-inflammatory fortified or supplement formulas actually even improve the ICU survival rate, which is really important. All right, so now I want to break down a little bit more detail about those different types of formulas. So why do we even want fiber? Well, kind of like what I just mentioned, we know that's a really important component to improve and support gut health. We're improving that. We're improving the patient's outcomes. So fiber was going to feed the beneficial gut bacteria. It's going to promote short chain fatty acid production like butyrate, and then also helps to maintain that gut barrier integrity. Okay, so the gut barrier is so important. However, unfortunately, due to, whether they're on certain medications or have certain treatment plans, it may be broken down a little bit. So with a higher fiber enteral formula, you're going to support more of a microbiome diversity. Remember earlier when I talked about how, it's important to have not just probiotics, but also having prebiotics. It'll also improve gut motility, which is so important. If we're not feeding the gut, we're not giving anything to the gut, it's not working. It's not moving things. Okay, we want to keep it in practice. So that's one other benefit of enteral formulas is using the gut. And then also what's really cool is having the fiber can actually enhance some cancer patients' treatment response. And that's always what we want because we want that treatment to work really well. One study had found that cancer patients on higher fiber diet responded better to their immunotherapy. And then one final note is that, making sure you have those short chain fatty acids within your enteral formulas can actually even help to boost that immune response. So no one food or, no one specific food is going to be immune boosting. You'll probably see that around a lot, like, hey, what's that one immune boosting thing? It's really about overall nutrition for our critically ill patients, and just having fiber in there can support that body's overall immune response. So never think like, oh, there's this one thing I'm missing for, immunity for my patients. No, it's really just general nutrition and just trying to add in all the components, which does include fiber and pro and prebiotics. A couple of different examples of those fiber sources that you're going to find in your enteral formulas will be like resistant starch. There's also going to be other like ones that will actually contain the pro and prebiotics, and then pectins. Sometimes, like I mentioned before, if there's a lot of fiber, it can cause bloating or even worsen gut motility. So like I said, you can't just throw a bunch of fiber and be like, okay, I know the gut needs fiber. Let's just throw some fiber at it. No, that's not enough. We want to make sure we're having the proper amount of fluids. We want to make sure we're monitoring those bowel movements, what's going on with that. And of course, having that dietitian really close on your team to monitor and support you with that. And then, higher fiber is probably going to be a little bit more best for stable patients because we're able to, really make, interventions and change things if there are complications. And sometimes that's not always, we don't have stable patients all the time. So that's not always an option, but trying to do those higher fiber formulas can really help them. All right, omega-3s. I love omega-3s. They're so much fun. Omega-3s are anti-inflammatory. Here's some examples, some food examples right here I put on this screen. Some salmon supplement. You can then supplement omega-3s. That's perfectly fine. Walnuts, nuts, seeds. These are your buddies, your best friends, okay? Even for our critically ill patients, but also for us, and even when our patients get better and feel better. We always want them to have omega-3s in their diet. So why? Well, omega-3s have anti-inflammatory properties. Like I already mentioned, going to support the immune response. They're going to protect that gut, and they'll just improve outcomes. So we need to be on the hunt for, okay, how can we get our amazing patients omega-3s? Here's a couple more specifics of how it's improving and supporting our ICU patients. One study had found that omega-3 enriched enteral formulas actually improved ICU survival rates and reduced inflammation markers. So if our patients are completely without omega-3s, they're missing out on a component that can really reduce inflammation and just help them survive and thrive and heal better. So making sure that omega-3s are added in as they shift the immune response from pro-inflammatory to anti-inflammatory. So remember, omega-3s are more anti-inflammatory. So if we can get enteral nutrition or supplement our patients with that, it can definitely help to support not only the gut, but also just reduce inflammation overall, which we know is a big issue. Here's the different ways that you're able to administer or provide omega-3s to our patients to support and help them out. As you can see here in the photo here, I just put supplements. It is okay to supplement omega-3s. That is perfectly fine. Yes, the previous slide showed food, and of course that's where our patients will get to, but it may not be when they're critically ill or in the ICU. So remember, you can have enteral formers that are enriched with fish oils. There's also IV lipid emulsions that contain those amazing omega-3s that you can get for parenteral nutrition. One thing to be mindful of, again, dietitians can help you with this and be on your team to watch closely with this, is you want to balance the omega-3s with omega-6s. Okay, so if your patient's getting too much omega-6s, that's the issue. We really want to have both. Omega-3s and omega-6s are both going to be supportive, but we don't want to miss out and go higher with the omega-6s and not enough with the omega-3s. And then also, of course, kind of how I talked about, one theme, that these studies have all found with supporting gut health is that earlier intervention. So remember, we talked about, those pro and prebiotics, within 48 hours. Well, same thing with that omega-3 supplementation. If we can do it, earlier on versus later when we're seeing our patients really ill or malnourished, we want to try to get those omega-3s, the early intervention. As long as it works for you and your treatment plan, that would be wonderful. Please do early intervention. So the next part I want to kind of talk about is what's next. What are some emerging therapies? These are all different things that are being looked at to really support gut health. As we know, it's going to reduce inflammation. It's going to improve recovery time. It's going to just help our critically ill patients so much. A couple of different things they're working on is microbiome targeted probiotics. So what these are is they specifically target certain helpful bacteria. And I'm not even really honestly sure how to pronounce that. Akkermansia. I apologize if I said that wrong. So just using more specifically targeted helpful bacteria can help them quicker a lot when it's more of that helpful bacteria, not just wide strains thrown at the patient. So looking at that, more targeted probiotics, bacteriophage therapy or phage therapy. Again, sorry about the pronunciation of that. So certain special viruses, unfortunately, are going to, the bacteriophage therapy actually kills harmful bacteria specifically without harming the good ones. So wouldn't that be really cool? So that's another thing that's being watched is it treats infections caused by antibiotic resistant bacteria, but it reduces that need for more broad spectrum antibiotics, which is very cool. Then we have butyrate supplements. These are healthy substances produced by the good gut bacteria like butyrate, overall helping support the gut. Why it matters. Why does butyrate matter? Well, it can help strengthen the gut lining and reduce inflammation in our patients, which obviously is important for our patients that we care about so much in the ICU. And then lastly, another emerging therapy, which is pretty cool, is what they're looking at. And again, these are all things that they're looking at and researching. And I made sure to share all the citations at the end of my presentation so you can read more. But these are things that are coming that we can be hopeful to look forward to that will help us in the ICU with our critical ill patients is microbiome sequencing for personalized care. Very cool. What they're looking at is they're analyzing the gut bacteria of very specific, so ICU patients, to guide personalized treatments. Again, this is making it not kind of just throwing all the pro and prebiotics at them, all the different things, as they're getting more personalized. It can help doctors choose better antibiotics and nutrition strategies based on their own unique microbiome. So that is really exciting and something that we can look forward to. Makes me very happy. All right, I'm going to summarize the key takeaways here before I pass it off to my next colleague. So basically, microbiome strategies, kind of to summarize, when we target the probiotics or symbiotics are both the pro and prebiotics, it will improve gut health, reduce infection, and then also just enhance our immune response in ICU. Of course, these are all things that we want for our patients. So really considering doing those pro and prebiotics. We want to be mindful of antibiotic use. So always clinicians who want to be thoughtful, choosing neurospectrum antibiotics, de-escalating when appropriate, and then that there are emergent therapies and way to look at specific areas of microbiome or gut health that we can use more specific strategies with our patients. Thank you so much for having me today, you guys.
Thanks a lot, Nicole. Very amazing presentation. I think the science of microbiome is very, very interesting. And I'm sure a lot of questions will come from the audience. Okay, so now we're going to listen to Hamda. Again, Hamda Al-Zuhair, she's the director of nutrition at Al Musa Hostel, Eastern Province of Saudi Arabia. She's going to talk about nutrition assessment for critical ill in the oncology patient. Floor is yours, Hamda.
Thank you so much. I'm sorry for the presentation. I really enjoyed the presentation by Nicole and Dr. Laviano. So today I'm talking about the nutritional assessment for the oncology patient and the role of the nutrition. So we know that by 2020 we have a lot of increasing prevalence of cancer, and 85% are experiencing cancer-related malnutrition. So my question is, how many patients are diagnosed with cancer receive a nutritional care, whether it's early or late, or even never? Personally, we came across some cases at the late stage, and we were hoping that we would be involved in the early stage so we can prevent more muscle wasting and fat wasting from the body. So what is the obstacles that we face to provide the care? First of all, some institution or healthcare hospitals or clinic, they don't use a validated nutritional screening tool for every patient, or at least for every encounter. They might just fill it with no accuracy. They don't ask the patient. So this is an obstacle. Also, once they fill the nutritional screening, we face another challenge or obstacle. It does not generate a referral for the nutritional assessment to a clinical dietitian to receive the care. So I'm not sure how many of us face this problem in their institution. Again, education and training of the healthcare provider to complete these tools that is validated and accurate, and to make sure that they capture more patients at risk and refer them for the proper care. We don't have sometimes policies in the hospital to regulate and apply in terms of the role of each healthcare provider, and again, when to refer and when not to refer. Personally, we discussed this with the oncologist, that why you didn't refer this case. They said you just diagnosed, and he's not at risk at this stage. But actually, by just diagnosis the patient at cancer, this is a trigger for a referral. Again, another last obstacle would be the patient choice. He might be positive for screening, and he's referred, but he chose not to come to us, and then they will have a complication from malnutrition. Again, malnutrition is very important in the care of all diseases, especially for cancer, as it increases the risk of readmission rate, increase the length of stay, and also the treatment interruption and tolerance. And this is a financial burden on the insurance company, on the healthcare system, and also on the patient, but also decreases the quality of life for the patient and increases severity of treatment and side effect. Also decreases the functional status of the patient. So what is the effect of cancer on the patient, which is a catabolic alteration? The first thing is the inadequate nutritional intake. The first cause could be anorexia, central nervous system level, and the secondary cause could be something like an obstacle, like an ulceration or poor dentation, obstacle in obstruction, chemotherapy alteration. And another thing, the second one will be the muscle protein depletion. It is the main aspect of cancer-associated malnutrition and can be measured by physical examination, and that we will talk about later. Also, the anthropometric measurement, it should be chosen very wisely for each patient. It should be personalized, because not every healthcare institution, they have the cutting-edge tools and equipments to do their job. they can be what is available on the chart, they will use it for their assessment. And also they have a bioelectrical impedance, which is another tool that we can use to measure the protein in the body. Again, this is the hallmark of cachexia. The third one, which is a systematic inflammation syndrome. Protein metabolism associated with altered protein turnover. So whatever we have is not enough. So we have loss in fat and muscle mass and increased production of acute phase protein. Again, it also affects the carbohydrate metabolism, insulin resistance, and impaired glucose intolerance. Lipid metabolism, increased lipid oxidation, especially in the case of weight loss. So there is a rise and increase in energy expenditure. Usually it's between 100 and 300 calories per day. If not compensated by increasing energy intake, it can cause a loss of about 0.5 to 1 kilos per week, or muscle between 1 to 2 to 3 per month. So we need to activate the nutrition care process module and framework. This is the best way to make sure that we have a multidisciplinary approach and collaboration and everything. So we will start by the screening and referral system. And then it will go to a nutritional assessment done by a clinical dietitian, then diagnosis, and then to identify the problem. And then we do the intervention, which is a multidisciplinary approach. It's not only clinical dietitian and physician. Monitoring, it's a multidisciplinary, and then we don't stop, we continue and repeat the same thing until we discharge the patient if he's hospitalized. Now, screening and assessment, it depends on each institution. We can choose from many nutritional screen tool, validated one, but the purpose of it, it should be sensitive and quick, because we don't have time in the clinic to do a very detailed assessment. It should be very quick and easy for them, for better compliance at least. It's regulated and required by healthcare quality accreditation. So for a hospital that apply a quality standard, it should be in place. It means that they should be audited for accuracy and should be measured as well. It can be performed by anyone, a trained nurse or a physician, to generate referral. And also this is important because you need to make sure that any new staff joining the hospital, they are aware of the tool that we use in this hospital, and they should be trained and they know how to reach the clinical dietitian for further assessment. Now, who is responsible to do nutritional screening in your healthcare? So this is something you need to go and check. In our hospital, everyone, as a first encounter, they will do the nutritional screening. It's a nurse job, it's a physician in the physician note, and as well as the clinical dietitian. So whoever see the patient as a first encounter will have to perform the nutritional screening tool. So again, go back to your hospital documentation and see if it's done and if it's generated a referral. Again, the nutritional screening tool, we have many of the screening tool. I prefer personally for the LTC clinic, the first one, because it's easy and it's enough for us to receive a referral. Whether he have poor appetite, there is a weight loss and poor oral intake, I think this is enough for me to receive a referral. And then from there, I can go and do a further assessment. We do have something called NRS. It's also for the hospitalized patient. It measures the disease severity, the age, impaired general condition, and it's also sensitive in the case of oncology. But the best one, I think, for ICU patient is the Nutri-Score. It's a very long assessment tool, but it's worth it. It's a numeric score, so you can measure the progress if he's improving or not. It takes a long time to complete, but it's really worth it. Now, the gold standard here, which is the patient-generated global assessment, it takes in consideration any change in weight, the food intake, the symptoms, activities and functions, and also the nutritional physical exam. Now, this tool is not easy to be completed by dietitians because they need to be really trained into doing physical examination for the patient. And then it's also numerical one, so you can also measure the progress of the patient. Most of the patients in oncology, they score more than 9, and then you can and every interval of follow-up and assessment, you can measure also the progress of the patient. Now, the cancer also, the goal of the treatment of assessment and intervention, you need to prevent or correct any nutritional deficiency, whether you started to do the intervention at early stage or late stage. We need to make sure that they improve their tolerance to the treatment, enhance the quality of life, maintain healthy weight, because it's not, we try as much as we can to prevent any further weight loss, because it comes from muscles faster than fat. Nutritional assessment should be more intensive in the care, in the ICU care. Also, we need to monitor the weight history. Now, this is a challenging thing in our hospital, and I'm sure in many hospitals, that we don't measure the accurate weight, or there's a poor reporting by the patient. So we cannot tell exactly how much they lost in percentage in the last 6 to 12 months. BMI, also another thing. If the weight is not accurate and we follow the weight on the chart, it might be not accurate. So we go for another parameter to measure the weight. Body measurement, we need to also, if you don't have a bed scale or the bed scale is not calibrated, you need to measure any changes in weight in the mid-upper arm circumference. Or you can use the bedside BIA, but you still need to have an accurate weight with that. Waist measurement is another thing for the ambulatory care, that you can also measure if there's an ascites or fluid accumulation. Type of cancer in the location and stage is important in your documentation and assessment, especially if you have neck and head cancer. They have higher prevalence of malnutrition. Surgical intervention or non-recommended is also another thing that you need to add to your assessment and intervention. Biochemical parameters, albumin versus pre-albumin, is not an indication for malnutrition, but as a disease severity. CBC, CRP, kidney function, electrolyte for fluids, and blood sugar as well. Diet intake, this is where you spend most of your time with the patient to take, because no one else from the healthcare provider would go through this detail unless there's a dietitian involved. You need to make sure that they don't have some kind of alternative medicine, because they go through then and they use anything like a green tea, reishi mushroom, and moringa. These things are very common with cancer patients because they believe it's a cure or it can help, but actually it can interfere with the medication. And you need to make sure also how much they consume from their energy versus their energy intake. Symptoms affecting nutritional status. This is the same what Ms. Nicole mentioned. We have a lot of complication that we need to add it to our care plan. Diarrhea or ulceration in the mouth, altered taste, constipation, there's no appetite, fullness, and many of them vomiting. So these things are important to add it to your documentation and assessment to make sure that you cover the assessment and nutritional plan. Chemotherapy or radiation or anti-inflammatory, it's another thing that you need to go through and review the medication to see if it's something they can do. Like example, chemotherapy can lower the appetite and you're working harder to stimulate the appetite by adding another medication. Vomiting could be a sign of some medication. So you can ask the pharmacist in the clinical rounds and see to review whether it's a side effect of the medication. So it's a multidisciplinary approach. Next slide is one of the tools that we have in our hospital, and I like to use it a lot, which is, it's a non-invasive test that can be completed within a few minutes. It's a cheap thing, and it's very quick, and it's an accurate comparing to a DEXA scan, which is you can feed this because this is a bedside, so you need to make sure that you have the height and weight which is accurate. You have to measure it before using this machine. It will give you the percentage of fat, if there is any waste in muscle, and water, hydration, distribution, and it's a good tool. Now, if you have the luxury of using the Dexa, it's a quick and pain-free as well, but some obstacle, it's expensive. Insurance company, they don't cover it, and but you can use it if they have it. It gives you also the same, it's a high accuracy, but if you don't, you can use the BIA. So this is something that you can be trained to use and read the report. Now, we can also use the functional markers for the patient, because when they lose muscle, it's not only the amount of muscle they lost, even the functional markers like endurance and strength and energy. You can ask them to do a simple test by walking for 10 minutes. Are they able to stand and do minor activity? Or you can make sure that they use the hand grip to measure their strength. And it's also a good indication for malnutrition in elderly. But okay, again, you need to make sure that it's a non-nutritional causes such as age, or there's a side effect of medication, or neuromuscular disease and activity. But it's a quick method. You can add it to measuring sarcopenia, muscle strength. So this is additional to your assessment tool. Of course, you need a lot of time to do this, but again, it's worth it. Nutrition focus exam, this is a head-to-toe physical examination. This is the only one that you don't look at the chart or the test, you look at the patient. And you need to go there and you need to examine for any cachexia muscle loss or fat store, ascites or anasarca. You need to inspect for nutritional deficiency by checking for pallor, stomatitis, glottitis, anemia, hair quality, and hair loss. Again, this is something you need to also look for vital signs, including blood pressure and pulse, skin condition for hydration, and edema. Things like looking at the body, again, from head to toe, to examine any waste, muscle wastage, or any fat wastage. Again, this is a special skills that a clinical dietitian, they need to be trained and use it frequently to have that to examine. It's a time consuming, but again, it's worth it and gives you a measurable parameter that you can see the progress of the patient. You can look at the orbital and temporal wasting for fat and muscle wasting, and it gives you also the severity of malnutrition. So it gives you from mild to moderate to high. Again, loss of fat, and this is actually, we don't like to see the patient in this stage because it's like the late stage and it's very difficult to reverse it. It takes some time, and we need to start early. So that's why we go back to the first step, which is the screening, and we need to capture as much as we can from the cases before they develop any waste. Assistant fluid accumulation is important because it's indication for malnutrition. So you can go back and you do the chart review, input, output, any weight change. But again, if it's not measured as a baseline and weekly basis for the ICU, it could be not accurate. Physical examination by doing the 4 stages of pitting edema to measure which stage they are in, and then you can also use the BIA to see whether they have extracellular fluids or any accumulation in the body. Now, again, when we want to complete our nutritional assessment, we need to make sure that they are on the higher side of nutrition. So we need to increase 20 to 50% of their nutritional goal, because they are catabolic, they are extreme stress and state of inflammation and surgical. But again, if they are in the acute phase in the ICU, we don't we do that immediately from day one. We go gradually, so we avoid the overfeeding of the patient. So the golden standard can be 25 to 35 using the actual weight, or adjusted in the case of obesity. Now, protein requirement, again, the secret word here is early malnutrition level. We need to start early by 1.5. We don't do less than that. And then in the severe, we can go up to 2. We can verify the amount of protein if we are giving the right one by doing the nitrogen balance example as below. So we can also measure this to make sure that we're giving them the right amount. Now, nutrition goal during treatment, whether the weight is healthy, we need to make sure they don't lose the weight from their lean body mass, and we need to maintain their weight, because our goal not to lose the weight. In case of malnutrition, we need to support any vital organ function and preserve host response to the weight, to the treatment, and may increase the energy and protein requirement. For the obesity with no malnutrition, again, the same goal. We need to maintain any loss in lean body mass and consider only modest weight reduction if it's an obstacle, but not in the ICU. Again, cancer cachexia, this is something very prevalent. About 71% of the patients in cancer, they have it. If you start early, you can prevent it. If you start late, it's very difficult to reverse. It's a poor response to therapy, increases susceptibility to treatment, and also related to immunity. Now, if it's in the pre-cachexia, which only lasts less than 5%, anorexia and metabolic changes, we can change the diet, the modification in the diet, meet the patient preferences. We can also supplement and we can boost the intake. But we can go more aggressive if he goes through the cachexia phase, if there is an increase of more than 5%, or if the BMI less than 20% and there is more than 2%. Now here you can introduce some supplement, maybe a 10% of the calorie intake or 20%. If the oral intake is less than 50% or 65%, this is something you need to take. But if not, you can skip it. Now in the refractory cachexia, which is like very severe cachexia stage, if the patient is able to take the nutritional supplement, why not? He can do it, he can take it, you can verify, but if not, we cannot force him to take it. We just meet their preferences and give them comfort in this stage. So malnutrition is similar to sarcopenia, similar to cancer cachexia. We just have to differentiate in the diagnostic criteria to make sure that all of them are considered as a protein energy malnutrition, but it's different from the intervention and the diagnostic criteria. Again, there is a difference if you compare the cachexia. It's similar to the infection. It have a weight loss, muscle loss, fat loss, anorexia, inflammation, insulin-resistant anemia, and functional. But it's not the same in starvation, and this is a comparison between the weight loss. Now, refeeding syndrome, this is something we have to screen from the beginning, because most of the cancer patients with severe weight loss, they are at risk in certain degree of refeeding. It could be moderate to severe, but it's very common problem for ICU for patients in the ICU, especially if they are starved and they are more than 7 days with no feed, significant weight loss. It's fatal shift in fluid and electrolyte. So what we see here, we see hypophosphatemia drop, hypokalemia, hypomagnesemia, thiamine deficiency, and hyperglycemia. So we need to monitor this and we need to screen. Actually, we need to do this on admission for the ICU immediately. And based on your policy, if your intervention is within 24 hours, this is more than adequate to screen for refeeding. But if your policy is 48 to 38, we skip the window of avoiding the refeeding. Refeeding syndrome management, we need to start very low. I know that some clinical dietitians, they're not convinced to start very low, but in this case, it's harmful to start high. We need to start as low as 5 kilocalorie per kg in the severe malnutrition cases, up to 10 in the moderate, and then you go gradually over 7 to 10 days. Actually, it will help them to overcome refeeding and they recover. If you do that, if you feed them because they are ICU and hypercatabolic, you are overfeeding them and you cause refeeding to happen. Protein is 1.5 to 2, and you can start by second day, by second or third day, the protein, you don't have to wait for the 10 days. Fluid, there is no need for restriction of fluid or formula. We recommend using the standard formula. It's better because it have the calories and the fluid as well. Thiamine, prior to initiation, we need to make sure that it is in the protocol. so we don't miss this step. And then we monitor. And the monitor is every 4 to 6 hours for some lab tests like blood sugar and electrolyte on daily basis. Depends on your institution how you can do it. Now, another we need to monitor with the help of the clinical pharmacist, we need to see the side effect of the medication because we don't want to have interaction between the medication and drug. We don't want too much drug or too little in the body, and we need to also aim for less effect on nutritional absorption. So some medication we prefer to keep them on an MPO when they have it to avoid any diarrhea or complication or interaction, or some medication they need to be taken with the meal. So you can review this with the pharmacist to come up with the best nutritional plan. Again, if it's multidisciplinary and it's done with proper communication documentation, we will provide the best and optimal care. Oral diet, our goal here to start early in the fed state to prevent any further malnutrition, especially in the starvation phase. Oral nutrition, oral route is the best and the superior that we maintain for as long as we can. We're aiming for 65% of caloric intake, less than we need to supplement. Challenges is the poor oral intake, medication side effect, chronic disease. Management, we always start with food without a nutrient supplement. We fortify the food. In case the oral diet is not sufficient, we use supplementation.
4 minutes, Hamda, please. 4 minutes.
Sure, I'm almost done. Oral intake, we have an obstacle is because of the anorexia and oral intake. So the outcome, all care plans are personalized. You cannot make one plan fits all. We need to make sure that we have degree of malnutrition. We need to have a priority to make sure we have a functional decline assessment and monitoring goal. Monitor and documentation. This is, I think this is the last slide. We believe in effective communication, multidisciplinary approach. Actually, this is a safety goal, proper communication. We need to respond, make sure that the patient respond to treatment, improve malnutrition in the score. We need to set a policy for follow-up intervals in our hospital or ambulatory care. So you need to make sure when you go back that your policy cover your role in everyone. And again, you need to audit your care plan versus the evidence, and you need to measure your care plan. Conclusion, nutritional assessment is a vital part of the overall medical plan of care. It allows us to monitor nutrition effectiveness, provide nutrition to assess with healing, shorter hospital stay, fewer readmission and complication, improve quality of life. So the steps are screen, assess, diagnose, intervention, monitor, and then repeat. You don't stop unless the patient is fine or discharged from the ICU. Thank you so much for your time and listening to me. Thank you.
Yeah, perfect, Hamda. It was great presentation. We learned a lot. I would like really to thank ICOM company Habiba for hosting that webinar. I would like we can start the session of Q&A.
It's okay. It's okay.
So please, Alessandro, be with us. Let me start the question for Alessandro. Regarding the glutamine, Alessandro, because there are a lot of talk about glutamine to reduce the radiation mucositis issue. Do you think glutamine is a friend or foe? Because people from molecular biology, they are telling it is a fuel for cancer cells. Is it really true in clinical scenarios or not?
So this basically, I can tell you that the clinical evidence regarding the use of glutamine in patients, for example, hematologic patients receiving high-dose chemotherapy or cancer patients undergoing chemotherapy are quite scanty, and more important, they're quite in contrast. So you can have positive effects and negative effects. So basically, at this time, there is no recommendation about the use of glutamine to prevent or treat the chemotherapy-associated mucositis. I have to say that, as you pointed out, from the molecular point of view, glutamine is a fantastic fuel for cancer cells, but in vitro. So we don't know in vivo whether the glutamine will be mainly used by the cancer cells or maybe mainly used by the gut epithelium. But the evidence so far, are not really so strong to recommend any use of glutamine.
Great, thank you very much. So let us look at the chat box. Really, somebody asking about the meeting is recorded. Yes, it's recorded. Wonderful session. I think you elaborated the difference between the chronological age and biological age. I love it. I have done 3 times in my life the biological age using DNA methylation, Howard's DNA methylation test. And the best time in my life when I was 15 years gap between the biological and chronological age. But you elaborated the role of that methylation test in critical ill patient or in hospitalized patient to assess their outcome. The first time to hear, and it's very fantastic for me, really. So when we look at the outcome, we look from biological point of view, not from chronological point of view. Can you comment on that?
Yeah, absolutely. I fully agree with you. And the paper I presented has been published a couple of years ago and suggests that it's a much stronger predictor of outcome. And now it's really easy to assess a biological age because you need basically the blood cell count, glycemia, albumin, creatinine, C-reactive protein, alkaline phosphatase, and the chronological age of the patient, and you can easily estimate. I mean, what is frequently used in clinical practice is this biological clock, which is called PhenoAge, which was developed by Morgan Levine, and the paper was published, I think, in Aging in 2018. It's quite simple. I mean, it's a formula. You have to develop that, but if you are good, you can also create an Excel sheet, and you just put the numbers in the Excel sheet, and then you can easily estimate the biological age of the patients. So you can easily use, and it has been now used in different settings, not only, of course, in the ICU.
Okay, so you believe that this kind of clock or this kind of what's called calculator, biological calculator based on biological marker can help also rather than to use the DNA methylation test. Is it correct? Or
It's
you want to
correct.
finish?
Yeah, absolutely. And I can tell you, I did some studies together with Professor Hanping Shi from Capital Medical University in Beijing, using very large databases, and it really predicts the outcome of a patient with cancer undergoing surgery. More importantly, it rapidly adapts to the stress, to the level of stress. So, for example, we are now conducting a clinical trial in patients admitted to the hospital, and we want to see whether the acceleration of a biological age at the admission and maybe the deceleration before being discharged, this is associated with, for example, with a better stay at home, or maybe with the length of stay. There are other countries who are thinking of using biological age to assess the health status of the population, because it's very easy. And you can say, for example, I want to implement this program. You don't have to wait 10 years or 15 years before you get the results. You just see whether there is, after 1 year or 2 years, a significant reduction in the population of the biological age. So
Great.
it's very easy.
Yeah. Okay, the question for Hamda regarding the ketogenic diet and its role in cancer growth. Really, can we starve cancer cell when we stop carbohydrate and use ketogenic diet?
I think I haven't seen any evidence for that, but usually a well-balanced diet would be enough if we give them the proper calories and proper protein intake and well-balanced. There's nothing, promoting for the ketogenic diet, and I'm not sure that if anyone from the speaker can agree with me or disagree, but this is how I know about it. So we only
Alessandro?
advocate for well-balanced diet.
Okay. Can we hear from Alessandro about that?
Okay, I fully agree. I mean, I can mention 5 papers saying that ketogenic diet reduces tumor progression, but I can also show 5 other papers saying that there is no effect. The issue here is that maybe, but again, I would like to underline, maybe there could be a role in patients with brain tumors.
Yes.
Maybe in that specific set of cancer, maybe there could be some effect, but for
For
all,
double benefit, I mean,
yeah,
for seizure issue and tumor as well, yeah.
exactly.
Okay, we have Akbar from Indonesia is talking about vitamins or micronutrient in cancer patient. Do you think there's a great role for micronutrient? I can like modify question about whole micronutrient, including vitamin and trace elements, especially iodine. Do you think that iodine has a great role in glandular cancer and has to be given regularly or what?
Well, you know, the issue of micronutrients is quite complicated because it's not easy to measure, to monitor them. In general, I would say that patients with cancer on a normal diet, on a standard diet without anorexia and cachexia, probably they get what they need from the diet. Now, what we know for sure is that, at least based on epidemiological studies coming from the US, so not sure where it works in Europe or in the kingdom. It seems that the supplementation with extra pharmacological doses of vitamins and micronutrients is not associated with any clinical benefit. Actually, sometimes it is also associated with a worse outcome for the patients.
Okay, thank you. So, Hamda, regarding fiber-containing formulas. I think Nicole talked about fiber-containing formulas. What do you suggest for cancer patient from your side?
I think
Is this for me or for
Yeah,
Nicole?
Hamda, for you, please, and of course.
For me, I'm really advocating for high fiber formula, but only after 7 days of the acute phase, so you can introduce it, so you can reduce the risk of diarrhea, and you can protect the GI function. So this is something, yeah, we recommend highly in the ICU for patients.
You mean the stable cancer patient?
Yes, only the stable cancer patient. Yes.
Alessandro, any idea about that?
No, again, the question is about the fibers. The fibers are key in patients with cancer, of course, and maybe they are more relevant than probiotics. I mean, I like a paper published in Science a couple of years ago showing that patient with melanoma receiving probiotics did not get any benefit, whereas if the patients were eating at least 20 grams a day of fibers, they had a significant improvement in survival. Now, we don't know from that study whether it's soluble fibers, insoluble fibers, but there was there's great differences between probiotic supplementation and adequate amount of fiber intake.
Yeah, somebody is talking about feeding and does have relation with when you stop feeding for some time. It means like for like some sort of prolonged fasting or intermittent fasting may help some patients or not.
Yeah, there are, for example, in Europe, I can tell you there are at least 3 research groups which are working on giving a long period of fasting during the day, meaning that the calories and the proteins needed by the patients are giving in a shorter period of time to allow a longer period of fasting, particularly the so-called overnight fasting, which is difficult to achieve in the ICU because you are always with a number of alarms and lights. But definitely they are working on whether giving the calories and the proteins in a shorter period of time and allowing hours of fasting is associated with a better outcome.
Same question about symbiotic means same like fibers regarding parental nutrition, contraindicated in case of the patient who is not hemodynamically stable. And in this case, what should we do if the patient is actually malnourished? And it's talking about to feed patient who is hemodynamically unstable. Is TBN is contraindicated as well or not?
Of course, if the patient is not hemodynamically stable, it's very complicated to start enteral feeding or at least meaningful enteral feeding. You can try very little, 10 milliliter per hour, just to feed the gut, but not to feed the patient. In general, if the patient is hemodynamically unstable, it's better to use parenteral nutrition.
Okay, so does a high dose of antioxidant diet before chemotherapy is helpful, or chemotherapy reduces antioxidants?
This is this is a key question because many patients actually are taking antioxidants when they are receiving chemotherapy, but this may not be good for them because some drugs actually act as they use oxidation to kill cancer cells. So if you use antioxidants, of course you can reduce the efficacy of anti-cancer treatment. So in general, we always recommend to tell everything to the doctor, even supplements, even herbal things or drinks, because some of them may have a negative effects on the efficacy of anti-cancer treatments.
Yeah, great. So a question from my side, as Hamda or Dr. Alessandro heard about DD water, deuterium depleted water in cancer patients.
If I may start, I mean, water is really important. I mean, sometimes as healthcare professionals interested in nutrition, we forget about water and dehydration. Just to come back to the issue of biological age, it has been shown that dehydration is associated with a loss of muscle mass, and more importantly, with an acceleration of aging, of biological age. So we have to be very cautious about the hydration status of the patients.
Yeah, a lot of experts telling about, especially in the field of sports nutrition, telling that dehydration is not a water deprivation only, but electrolyte as well. So they should suggest to you when you drink electrolyte containing water, not only simple water. What do you think about it?
It could be, but I think that it's a different perspective, because if I am a sport physician, a sport nutrition specialist, my goal is to improve the performance. But actually, in a patient, I want to improve the long-term outcome of the patients. So not really focusing on how strong he is or she is, but how can I help him to fight the negative effects, for example, of anti-cancer treatment or maybe of an acute disease.
The last question from the audience is parenteral nutrition contraindicated in patient on chemotherapy?
Not necessarily. Usually, of course, you don't infuse parenteral nutrition when the patient is already receiving chemotherapy. So you don't really use the two lines and infuse simultaneously chemotherapy and parenteral nutrition. But there is no contraindications in using PN when the patient has chemotherapy.
Okay, great. Now, I would like to thank also Nestle company for sponsoring the webinar, and especially Mr. Ayman and Mr. Abdurrahman. They are going to share with us like 5 minutes about their new websites called My Cancer, My Nutrition, which can help thousands of patients with a nutrition problem in cancer. So let us to hear from Mr. Abdurrahman Al-Deeb. Floor is yours.
Thank you.
Thank you very much. Is Abdurrahman ready to share your screen?
I'm here. I think Habiba did everything, but we're still facing the same issue for unknown reason. But we agreed that she will share the screen from her end.
Yeah, that's fine.
So, okay, sorry for this, and hello everyone. At the beginning, I would like to thank all of you for joining us today for this important webinar, and also I would like to thank all the speaker, Professor Alessandro, Dr. Khaled, of course, for making this possible. Dr. Hamda and Nicole as well. So my name is Abdurrahman Deep, and I'm a pharmacist acting as Associate Brand Manager, leading the adult medical nutrition and oncology portfolio across Middle East in Nestlé Health Science. Today, would you please move next? Today, we are pleased to share. I'm the one who will share. Okay, she gave me the control. Thank you. We are thrilled today to introduce My Cancer My Nutrition website. What is My Cancer My Nutrition? My Cancer My Nutrition is a website which is specifically designed to empower both cancer patients and their caregivers. Actually, this initiative is not only about providing information, it's about enhancing the support system and the ecosystem for those affected by cancer. It helps them navigate through their journey with confidence and across the reliable sources. As you started your speech, Dr. Khaled, with fact and fictions. Most of cancer patients, according to our recent social listening study and report that we did last year, we found that a significant number of cancer patients and their caregivers, they often turn to unreliable online sources, which can lead to misinformation, misleading, and confusion. And I know this is something that you may suffer on a daily basis. So this highlights actually the critical importance and the critical need for something which is trustworthy, something reliable and packed with resources and science to support those patients and their caregivers on across the whole cancer surgery. So this is the idea. This is why we are here, why we initiated such a product or such a tool across the Middle East. Actually, it is available on a global level with both English and Arabic versions as well. So, sorry, it's really hard to control it because I'm controlling Habiba's screen. Okay. Okay. Because in Nestle, we believe in food at the heart of life and can make a real difference in cancer. This is what we believe at the heart. Nestle Health Science is a leader in the field of nutritional science. We are committed to redefine and reshape the management of health when it comes to the extensive portfolio, transversal portfolio we are offering across the cancer surgery. We need our patient, we need the cancer patient to understand more, to learn more and get the credible information that they need. That's why the website, in the first place, aim to raise the awareness of the importance of the nutrition and to present the nutritional solution that exists in the oncology ecosystem. So our goals are very clear. This is a snap or a screenshot up there for the Arabic version of the website. Our goals is to be a compassionate support. We want to support cancer patients by providing those information, the credible information, cancer-specific information. We need to transform lives. We want to raise awareness, as I have said. We need a product portfolio awareness. And this is very important. Yes, everyone in the healthcare system, you are, as a respected healthcare practitioners, know what is right for the patient. You prescribe it, but nobody is going to expect what will happen in their homes. Nobody is going to expect what is the effect of their caregivers. How can they guide or mislead them? Maybe sometimes it happens according to a false information or something. So there is unmet demand here in the cancer nutrition knowledge. There is a patients and the caregivers who are not aware of a lot of things going, because it's science at the end. So in order for us to simplify this science into a language that the patient can really digest him and his family, we offer also a portfolio. And it's not only about the product. Yes, it's not something commercial from a standpoint here, but we need him to understand the value of nutrition. Yes, you are taking a high protein formula, for example. You are taking a thickener for your head and neck cancer status. We need him to understand more behind the brand, more behind the value of the brand rather than the commercial standpoint. So this is the QR code here. You can use it to log into the to surf the website. It's www.mycancer-mynutrition-mina.com. I hope this didn't take so long, and thank you for giving us such an opportunity.
Thank you, Mr. Abdurrahman.
Thank you, Doctor.
Thank you very much. I believe it will be a very helpful website for the cancer patient and their family. I would like to end the session now. Thanks, Alessandro. Thanks, Nicole. Thanks, Hamda. I would like to thank really ICOM for really conducting that webinar. And I hope to see you again. Next webinar will be on April 14. We'll talk about renal transplant nutrition from different perspectives. Thank you very much. See you again. Thank you.
Bye-bye. Thank you again.
Bye. Bye.